Now approaching the last sections of our program, and I'm happy to introduce to you Iga Rawicka. She is chairperson of EuropaColon Polska in Poland, and she is member of the World Pancreatic Cancer Day Committee and member of the scientific committee member of the Central European Cooperative Oncology Group, the COG, focusing on Pancreas Cancer Academy. And she is a chair of the Digestive Cancer Europe board. Thank you, Iga. We are happy to have you on board today, and we are ready to listen to your experience as patients, advocacy organizations, representing advocacy organizations. So I have a few questions to you, just to have your impressions and to channels the discussions from the points of view of patients. The first one is, what is, in your opinion, the level of involvement of patients in defining innovative treatments, for instance, participating in trials or giving comments as patients experts?
Thank you, Luisa, for the invitation and the possibility to give the patient's perspective. Indeed, with 3% of research budget that goes into pancreatic cancers, there is not much possibilities. Even so, usually they are Western country patients, like in UK, Germany, Italy, France, Spain, that can really benefit from having clinical trials in these countries. So patients from Eastern European countries or Southern European countries are not eligible to benefit from these possibilities and to have option of the treatment if there is nothing left for them. So this is the main problem, and it is really very hard for example, people from Poland, Czech, from other Eastern countries to go to the West and then to be a part of the clinical trial. So sometimes we are thinking of how it could be possible that we benefit from this more than this is now, except from the fact that there is not much clinical trials in pancreatic cancer.
Mm-hmm. And how is the access to a new or innovative treatment, the access level? Are these treatments accessible to patients or not?
So again, it's the same situation. For the patients from the Western countries, it's much easier accessible. For patients from Eastern countries, is much less, especially that the process, even though we have a central registry already in Europe, but it is still not accessible at the same time as it is in the West. So we still are waiting sometimes years for a new drug to be available, especially that in pancreatic cancer, we still do not have so many options as, for example, in colorectal cancer or other like breast cancer. So it's again another issue that it's really hard to solve.
Mm-hmm. And so what can we do then to improve the patient's chance to survive?
That's the big question. So what we are doing now, wherever I am involved, we are trying to, first of all, raise the awareness. And this is by doing many different activities. First of all, to raise the awareness of risk factors and of symptoms, because if you can detect the pancreatic cancer earlier, it is possible that more people will survive. So this is very important. We should change the health system's approach, that they will not neglect possibilities to for early detection within pancreatic cancer. So for us, there is hope, for example, with the new possibilities such as this new tool, which will be possible, accessible from the, like in colorectal cancer, that you can detect it from the stool. So this would be a really huge chance for the people to have the access to the treatment earlier, because the disease will be earlier detected as such. So this is one point. Another point is that for the patients and families that are already having pancreatic cancer, there should be some kind of protection program for the families that are that have pancreatic cancer. For example, with BRCA mutation, we in Poland have this kind of program for breast cancer, ovarian cancer. So we know that the same mutation could be in prostate cancer and in pancreatic cancer. So we are now applying to involve also pancreatic cancer and prostate cancer to be in this program. But this kind of program should be conducted in other countries in Europe. And this would really help people to be protected and screened earlier. So this is really very, very huge lack of unmet needs of the patients.
Mm-hmm. So there is the hope. There is the hope.
Well, we hope there is hope. And one thing more which should be added, that we all know that pancreatic cancer has a very bad PR. Whenever the patient and the family hears that you have pancreatic cancer, they think of people were mentioned here, like Patrick Swayze or even Steve Jobs. They had enough money to, to be used to survive. But even the huge money could not help if you don't have the treatment, if the disease is aggressive or it is not detected early enough. So we should really put a lot of effort to make pancreatic cancer more aware of, but also that when the patient hears the diagnosis, we should change the communication even for the media perspective, that this is what we did in Poland. We converted the communication from the negative one to the positive one, that you really still have a chance, there is hope. And because of the earlier diagnosis, you have a chance. And this should be something what we should focus on. What we started this year, we did, and last year, we did a very nice program, educational one. We started from Where is Pancreas program. This is a detective story made from 3 chapters and a webinar, and you can go on our website, you can watch it. And by this, I can even hear from my colleagues and other people that because we published something on our Facebook or somewhere else, people started to think about it. Okay, so this might be my case. Yeah, so this could be the solving of the issue.
Mm-hmm. So this is your example. What you mentioned is a very good example of how it is important to cooperate to have an early detections of the illness. No? So the cooperations between patients' organizations and medical institution is very much important, advisable in order to inform people, the general public, about this illness.
Yeah, exactly.
Yeah. So thank you all for your contributions. We have now, we are in fact out of time, but we can devote a few questions to our speakers if there are any questions from the audience. So you can either write your questions in the chat, or if you want to raise your hand, you can have the floor for your question.
Sorin, no place for Da Vinci surgery in pancreatic cancer?
Yeah, of course, it is a place quite high, and looking forward for people who have money to buy a Da Vinci and to use it. It's still the same expenses. It will be a nice future, but I think not in a global crisis like this, but it will be a nice future. Better, I think, than laparoscopy.
Thank you.
Any additional comments on this? Maybe Professor Paiella, Salvatore, you wanted to comment on this?
As a surgeon, I think the same thing of
Okay.
Professor Barbu. We have the Da Vinci, but very few patients still can benefit from its use.
Mm-hmm. Okay, thank you. Any other questions?
Yeah, I would like to ask Salvatore, because I had a short stay in Verona in 2016. At that time, you had the first results. You succeeded to reduce the complication for radiofrequency ablation. I'm talking to reduce the complication at half. You had for the first patients. And I remember Roberto Salvia in open surgery, before resecting the cancer, he did a radiofrequency ablation because the exterior of the tumor should remain. And after that, in the same session, doing the resection. Is it for immunity, tumor immunity stimulation, or is he still doing this?
No, I think it was just one case, because that they thought at the beginning that they would have gone forward with resection, but at the end they resect the tumor. So we don't do it routinely at all.
Okay, okay. Thank you.
Okay, last question.
Yeah, I'm not a surgeon, and I may say nonsense, but Professor Bichler from Heidelberg just said that you could replace the splenic artery when the mesenteric artery is invaded by the tumor. So you can use the splenic artery to replace that. Is that feasible?
Yes, it is feasible, but it's not a routine. You know, in high volume centers, when they had a vascular surgeon close to them, it can be done, but it's not a routine.
Can I comment as well?
Yes, please.
Professor Carrato, yes, as Professor Balbo has said, almost everything can be done in the intraoperative room nowadays. However, we try to do only what is useful and what can be useful in the future for the patient. Let's think about the rate of quality of life impairment that the patients experience after a vascular resection, arterial vascular resection of the superior mesenteric artery, because unavoidably you will extirpate some nerves surrounding the superior mesenteric artery, and patients will experience chronic diarrhea. Sometimes they cannot receive adjuvant therapy after resection because of the quality of life impairment. So everything can be done. It's just a question of thinking when you have to do it.
Thank you very much, Salvatore. Very useful.
Yes, then I think we come to a conclusion. of this workshop. Thank you to all our speakers for the very, very interesting input you gave to us. Thank you for the points of view of the patients, Iga, and thank you for your participations. So all the documents, the presentations, and the video registrations of the workshop will be available online on our website, and we will inform you when this will happen. Thank you a lot for being with us today. Bye-bye.
Thank you. Bye-bye.
Bye to everyone.
Bye-bye.
It's been a pleasure. Thank you.